So, good morning.
Morning.
Thank you. I am not weeping, because of the stats that were shared earlier. I had something blow in my eye as we were walking here this morning, so forgive me. Let's see if we can get it going. There we go. So, I'm SILAS Buchanan. I'm with the Institute for eHealth Equity. We're a Cleveland, Ohio-based social impact consulting firm. Don't do much consulting anymore. I wanted to stop consulting, stop talking a little bit about what we do and really get back into the field and make some of it manifest. As the name infers, we're concerned about an exacerbation of health disparities because of technology, right? So we spent some time working with underrepresented populations on raising the literacy around the benefits of adopting and utilizing technology to improve health outcomes for them and their families, create some independence by them adopting and utilizing technology. On downstream, upstream, you've got HIT developers in New York, Silicon Valley, Cleveland, everywhere. They're ideating and innovating on tools, trackers, devices, and applications without the input of underrepresented populations. And so we've got to address that at the same time. Some things that we specifically do are build social network systems, platforms for secular and non-secular community-facing organizations that are embedded in underrepresented communities, right? These are the trust brokers. These are the community-facing organizations in communities where community members live, work, play, and pray, right? These are the influencers. If you are a church-going person that's fairly healthy, you may go to the doctor once a year and you'll be there for 20 minutes. If you go to church, you could be there for 70 hours a year, right? So it's important to empower these trust brokers that are embedded in communities with some of the messaging as well as the mechanisms, right, to carry the water in ways that it needs to be carried. So for this particular panel, and I'm so pleased to be here, we were asked as a panel to contemplate a handful of questions, and I honed in on what you see here. Can virtual trials be positioned and designed to increase inclusion of underrepresented populations? I say absolutely yes. Are there special design trial considerations to address the unique socioeconomic factors that underrepresented populations face? Social determinants of health, and I say, absolutely yes. Can data-driven insights be generated at multiple levels, frankly, to build knowledge and access on access and equity considerations? I say yes again. And are there tools on the horizon that can be leveraged to improve inclusion? We're building some of those, and I'll share those with you guys today. And are there specific disease areas in which access and equity can be improved more immediately? Well, sickle cell anemia comes to mind right away. Of course, I think that's obvious, but frankly, it doesn't matter the chronic illness. The morbidity and mortality rates of people of color is completely out of skew with the white population. So it doesn't matter what chronic illness it is, right? We're behind the 8 ball. So to begin to stand up our platforms, the social networks, as I've described, the desire for us is to work both secularly and non-secularly. So we've established some working relationships in the field. One of them is with the AME Church, right? The AME, for those who don't know, and I'm sure many of you do, is the largest mainline historically black denomination in the world. We're talking 2,000 congregations and 2 million members worldwide. We own and manage amechealth.org. It is the official health information channel for the AME Church. Of the 2,000 congregations worldwide, 30% of them have a dedicated health minister. That's somebody embedded in the church, designed to facilitate relationships. And so we're just beginning to stand that particular platform up, as well as ourhealthycommunity.com, and I'll share both of these with you guys today. Again, desire to work secularly and non. We're standing up ourhealthycommunity.com to put these community-facing organizations on a singular social network, because if you can work through them, if you can drive programs, if you can drive campaigns around health improvement and wellness through them, you'll more effectively reach community members. And we do our work for the benefit of our clients. We are a for-profit. which are healthcare payer, provider, government, and academic stakeholders. Haven't done much in the clinical trial space, and so hopefully we'll have some conversation as we go and as we grow. The platform, ourhealthycommunity.com, is exactly as mentioned. It is designed as a social network. If we can pull these organizations together and strengthen them by connecting them, I think we're all gonna win, particularly our clients, but most specifically patient consumers. We recently signed an MOU with the City of Cleveland Office of Minority Health to put 30 community-facing organizations in Cleveland on this particular platform. And that may provide us access. We haven't done it yet. We're in the process. That may provide us access to around 30,000 targeted community members. So we want to provide some initial training for these community-facing organizations. It's very intuitive. It's much like Facebook. So whether you are a faith-based organization or not, right? Because not everybody goes to church, right? So you could be a barber, a beautician, a nail tech, a corner store. It really doesn't matter. We want you on the platform as long as you have access, and we'll give you a little bit of training. We then want to provide some really campaign-specific training, right? So we're doing a campaign right now with a group of stakeholders in Cleveland around infant mortality. In Ohio, infant mortality rates are just, they're nuts. Black babies die at 3 times the rate of white babies in Ohio. In Cleveland, maybe I am weeping for this one. In Cleveland last year, black babies died at 6 times the rate of white babies, right? So we're working with HIMSS, and I'll get into some of that detail in just a minute on solving for that. So we want to provide some campaign-specific training. When we have conversations with these community-facing organizations, we hear a repeated refrain of them tiring of whoever has the NIH grant of the moment, or the RWJF grant of the moment, or Kresge or Kellogg grant of the moment, or whatever it is, knocking on the community's door, typically through the pastor's office, asking and looking for access. And I'll go back to Cleveland as an example, but this is true everywhere, right? So the Cleveland Clinic, they've got umpteen NIH grants, as well as RWJF grants, as well as Kresge, Kellogg, and ARC, and others. But there's Case Western Reserve University, and Cleveland State, and Metro Health, and university hospitals, and so everyone is seeking access. And these community organizations, nor community members, are invited to the table while the grants are being written to meaningfully contribute to what the it is, right? Nor are they written into the budget. So there's no equity. At the same time, they're asked to do much of the heavy lifting. So we want to provide some specific training for the infant mortality awareness campaign that we push forth. We took the collateral material and we began to share it with these community organizations, and they immediately said, "Hey, don't do this, do this. Use this sort of imagery, use this sort of language," and it just changed exactly and completely how we thought about it. Ultimately, what we're after is a queryable database that will allow us to succinctly connect the needs of community members and these community partners with our campaign sponsors. So as we onboard, for example, these 30 community organizations in Cleveland onto our platform, we've already begun some conversation with CareSource, who's the largest Medicaid provider in the state of Ohio. They know exactly where their non-compliant diabetics are, right? Down to the zip code. We want to be able to say to them, well, in that particular zip code, or in those particular 3 zip codes, we've got 8 churches, 5 barbers, 6 beauticians, and 3 nail techs with trusted and consistent access to 30,000 people. You want to access 1,000 of them. Great. We'll drive that campaign for you. We only need 5 of those 30 organizations, but guess what? Those 5 organizations, they're going to go in our budget, right, as we push forth with a particular campaign. It's important that we also build mechanisms that allow us to, through the trust brokers, consistently communicate with community members. So the thing that we're doing around infant mortality is called Battle for Our Babies, by the way. And so we stood up Battle for Our Babies on Instagram and Twitter and Facebook, and we're allowing the community to push messaging through those channels, through these trusted community-facing organizations, and of course, on their own. I think Denny mentioned yesterday, Smart on Fire, another goal of the platform, and maybe it was John White who talked a little bit about EHRs, and he didn't specifically mention Blue Button, but it's important that we integrate this platform with Smart on Fire tools, trackers, applications, devices, Blue Button, things that allow community members to own and control their own data and information. And it should come through a platform that is kind of built for them purposefully. And of course, data and data analytics are critically important, and we want to share data up and down the food chain, directly with patient consumers, with community-facing organizations, as well as with our sponsor partners. It's interesting that whoever is doing work in communities who tend not to leave much of anything behind, they don't even leave data behind, right? So even if data was left behind, quantitative and qualitative data in a lay format that executive directors of 501c3 organizations could then leverage to increase their ask of local foundations, it's a win, right? So that's what we're building. In real-world example, this is just a shot of the amechealth.org platform. Along the bottom, you'll see some of the things that we are pushing out to that community. Some of these are ads, basically, that they've asked us. AME is our intimate partner here. So whether it's something around the Affordable Care Act and open enrollment, or unfortunately, there's an active shooter preparedness course that faith-based organizations have got to go through. The one that's here, Uniform Services University, wanted this to go up as an ad. They said that they really did not have budget for us to work with them, actively to push the messaging out around ERE, exertion-related events, and sickle cell trait, right? To congregations and community members, and it's a little bit unfortunate that they didn't have budget to do that. When we initially pushed off from the doc with this sort of work, we started as a 501c3, and we got a $100,000 grant from Aetna Foundation, and we launched something called Text for Wellness. And we asked pastors in 5 faith-based organizations in 3 cities, Atlanta, Dallas, and Columbus, to chat a little bit about health from the pulpit, and then do something counterintuitive. Ask folks to take their cell phone out in church and text the word healthy to our short code. And what we did is delivered an evidence-based, CDC-based healthy eating, active living campaign, all via SMS. There were 4 touches a week: message, 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 and then question, right? Over 6 months, we had, just through 5 churches, we had 2,500 participants. We had a 43% response rate to questions that we asked, and most telling, we had 0 opt-outs. Nobody left the program, right? Unfortunately, we heard words that drove me out of the 501c3 space and back where I'm really most comfortable, in the for-profit space, and that was our funding priorities have changed, right? So, right? So as successful as it was, their funding priorities changed, and they wanted to go in a different direction. That was a real bummer on one hand. On the other hand, it really did push us into a for-profit model that we believe is going to work quite well. I mentioned ourhealthycommunity.com and Battle for Our Babies. Here were the sponsor partners for the Battle for Our Babies Health Developers Technology Challenge. And I'll just give you some of these because they're acronyms, but it is an amalgam of payer, provider, government, and academic stakeholders on this list. These are folks that wrote checks. It is the City of Cleveland Department of Public Health, Cuyahoga County Department of Health, CareSource, the largest Medicaid provider in the state, First Year Cleveland, which is focused exclusively on reducing infant mortality rates in Northeast Ohio, and housed at Case Western Reserve University, and others. And as mentioned, hold on, because I'm still weeping here. As mentioned, with our partner at HIMSS, we stood up Battle for Our Babies, and what we did, we took 3/4 of a day, and we invited a handful, and it wound up being more than a handful. We had 85 community leaders show up at the HIMSS Innovation Center, which happens to be bolted onto the Cleveland Convention Center, which made HIMSS a natural partner for me. We invited them to chat with us, really to not necessarily do a lobotomy, but just to extract some information, have some design thinking exercise go on, right? around a tool, tracker, device, or application that they would like to see developed to address infant mortality from one of three perspectives: stress, dads, or community health workers. What could those cohorts use to impact infant mortality rates? Well, HIMSS took, and their contribution to this was to take and to push this out to the developer community nationally, actually internationally. And we left the lines of communication open between these thought leaders that were in the room and the developer community for 5 weeks, so that the developer community could parachute in and ask questions on an ongoing basis while they're in the ideation and the innovation process, right, around developing something to positively impact infant mortality rates. Long story short, we wound up with 45 submissions, one from Uganda, one from Ghana, a handful from San Francisco, really from all over. We narrowed that down to 19, then 12, and 2 weeks ago we announced the three winners. There was a team from Boston Medical Center and Northeastern University. They teamed up. I think they got second prize. First prize was Ohio State University and Nationwide Children's Hospital, and then there was also a student team from Rochester Institute of Technology that placed as well. Cleveland Foundation was kind enough to put up the prize money, so it was a $10,000 first prize, right? $8,000 second, $7,000 third. It was fabulous. So HIMSS and I are now partnering to market, we'll say, these sorts of challenges. Our next venture, it appears, will be with Children's Hospital in Los Angeles, as they want a similar challenge around adolescent homelessness and or mental health issues. It's important that we just don't put challenges out without having a mechanism to hear what the community wants. Things can't be ideated and innovated in a vacuum and then thrown over the wall and expect people to use them. So as I kind of power to a close here, we do our work with strong, and this is the secret sauce basically, strong ethics of engagement. It's important as we talk to community organizations and community members that we acknowledge histories of discrimination and marginalization. They want to have these conversations. Social determinants of health are driving quite a bit. I want to go back real quick. There we go. Are driving quite a bit of health outcomes negatively these days, and it's important that we understand that. We want to document community strengths, and we want to ensure that we have local knowledge and we understand culture intimately. We want to build capacity and focus on systems development and sustainability, and seek opportunities for co-learning. We want equitable partners with our community-facing organizations. The last slide. At the end of the day, our outcomes are centered around community members that are actively engaged in receiving information and also sharing information. Creating these democratized feedback loops are important. We want our community partners, these community-facing organizations, to gain access to tools that enhance their ability to reach community members. We also want the community partners to receive accurate and timely feedback reports. Again, data. And our sponsors will always have consistent and trusted access to the community organizations and members that they need. Thank you guys for listening.